Hello, this is our heart block presentation, which is the final presentation of our cardiac education series. So if you've watched the other videos, thank you. And if this is your first one, also thank you. I hope you enjoy. So starting off, we have first degree atrioventricular heart block, or AV heart block. And this is when there is a delay at the AV node. Therefore, your EKG will look normal, but the PR interval is prolonged. So the message is just delayed, or the signal is delayed. Your patient can be asymptomatic. This may be considered a normal finding with certain drug therapies that your patient may be receiving, like procainamide, quinidine, certain beta blockers, calcium channel blockers, and digitalis. So we may see this with our preeclamptic patients or hypertensive disorder patients who are getting that hypertensive therapy. Some other causes can be rheumatic fever, AMI, myocardial infarction, or increased vagal tones. So when we break it down on an EKG strip, again, our EKG will appear normal with the exception of our PR interval, which will be delayed, again, because the signal is not reaching where it needs to go in a timely manner. So this is a great visual of those prolonged PR intervals. I really like how this breaks it down for us, for those visual people. So next we have second degree AV heart block. And this is when impulses from the SA node fail to reach the ventricles, which can result in more P waves than QRS complexes. Your P waves will occur at regular intervals, and there are two types of second degree AV heart block. There's the second degree type 1, which is also a Mobitz 1 or a Weckenbach, and there is the second degree type 2, also known as a Mobitz 2. So when we break them down even further, our second degree AV heart block type 1 or Mobitz 1, also known as Weckenbach, this is where the block occurs at the AV node, and your impulses in the SA node take longer to conduct, which results in a completely blocked cycle. You have a P wave with no QRS complex, and some causes of this include ischemic heart disease, inferior wall MI, and effects of drugs such as digitalis, beta blockers, verapamil, and increased parasympathetic stimulation. And one trick that I learned going through school in my early nursing career to remember this was Weckenbach is going, going, gone. So each PR interval will successively get longer until it drops a QRS complex. And you'll see that in the next slide. So here you can see a great visual because our PR interval is slowly getting longer with each QRS complex, and then it drops. So that's a nice little visual for that type 1 second degree block. Before we move on, if anybody's looking like this little girl in the picture, no fear. That was exactly what I looked like when I was doing my research and trying to understand these heart rhythms myself. And I've been doing this for going on 15 years now, and it's still challenging. So I understand, but we're going to try to get through it together. Have no fear. I just thought I would add a little comedic humor to the presentation. But moving on, we have our second degree AV heart block type 2 or Mobitz 2. This is when we have a conduction delay that's below the AV node, which happens in the bundle of His or in your bundle branches. So not every P wave will be followed by a QRS complex, and your PR interval may be normal or it may be lengthened. Some causes: coronary artery disease, acute myocarditis, or an anteroseptal MI. And your symptoms are going to be related to your ventricular rate. So if your ventricular rate is normal, the patient may be asymptomatic. If your ventricular rate is abnormal, then your symptoms will follow your ventricular rate. So here is a very nice visual of your Mobitz type 2. So you can see the normal cycles here in the squares or rectangles. And then where the arrows are, you have random P waves that are not associated with a QRS complex. So just a nice visual representation of what that looks like. And last but not least, we have our third degree or complete AV heart block. And this is when the atria and the ventricles beat independently of one another. So that's fun. They kind of just do their own thing. Some causes: inferior wall MI, certain drugs, digitalis, propranolol, verapamil, or damage to the AV node. I'm a visual person and I really like these images. So here in the red circles, you can see all of the P waves. Some of them are not associated with any QRS complex, which then indicates that impulses are not making it past your AV node. So again, your P waves are originating in the atria, where your QRS are the ventricles. So you can very clearly see here that they are very independently doing their own thing, which is not conducive to blood flow, right? Pumping of blood. I think I've shared this image in a previous presentation. If I haven't, I am now, because I think it is a great visual and really does a good job of breaking down the different types of heart blocks, making them very easy to see, very easy to define. So your first degree, you just have prolonged PR intervals. So there's a delay there. It's taking a little bit of time. Your second degree is that Mobitz 1 or Wickenbach, going, gone, right? So you can see your PR intervals are getting longer and longer in distance, and then eventually your QRS drops completely. In your Mobitz 2, you have your fixed PR interval, so it's not lengthening like a type 1 or Mobitz 1. It's staying fixated, but it does eventually drop that QRS beat. And then your third degree, again, is where the atria and ventricles are independently doing their own thing. They're independently beating. So your P waves do not necessarily have a correlating QRS complex. So this does a really, really great job of breaking it down to make it easy. And those are a couple of my references that I used. Thank you for watching my cardiac education series on heart blocks.